welcome to the show. Dr. Phillips has the day off to go save those piggies, and today we have vascular registered technologist Jill Somerset, who is the Global PAD Association's Diagnostic Innovative Champion for 2024. We absolutely love her and everything she's doing to help patients and innovate around peripheral artery disease, which is that poor circulation and mainly the legs. We're going to get into how her innovative approach to measuring blood flow in the smallest arteries in the feet is helping a general surgeon in El Salvador reduce diabetic amputations that are related to poor circulation, again known as peripheral artery disease or PAD. Dr. Fernando Javier Martinez Irigoyen is going to be joining us to talk about how his nation, with about 12.5% of the adult population struggling with diabetes, he's trying to help these patients, and he is going to share his plight to save life and limb. So excited about this show. First, I want to welcome Jill, my guest co-host for the day. Thank you so much for being here.
Well, thank you, Kim. It's really nice to be here. We just saw each other a couple of weeks ago at NCBH, and I was commending you on all the amazing work that you do. You're such an incredible patient advocate. And then I realized, oh my gosh, I need to connect all of us with my friend and really incredible general surgeon, Dr. Irigoyen in El Salvador. And I just thought this would be a really delightful conversation to really share the incredible work that he's doing and to share the story of our friendship and how he's implemented this technique called pedal acceleration time, which is ultrasound of these small little arteries in the foot. And we can determine what the perfusion is like in the foot. So with that, I'm so excited to introduce Dr. Fernando.
Hi, Dr. Fernando, all the way from El Salvador. Thank you so much for joining us.
No, thank Kim and thank Gil for the invitation. For me, it's a pleasure to be with you and try to share with all of you the work that we are doing in El Salvador, trying to avoid a major amputation in our diabetic patients.
Yeah, I thought it would just be really nice for Dr. Fernando to talk about how actually we met over the pandemic. I think it's a really lovely story. So I'm just going to turn it over to him and share that journey that we've had together.
Yeah, it's kind of be funny because during the pandemic, we cannot able to fly to see other people in person. So I started looking in the social media, what to read, what to do, what to learn more for my career. And in Twitter, many years ago, because now it's X, and that time called Twitter, I started looking for this research of PIT Doppler help in diabetic foot. So I start reading. So we have a friend in common that from Mexico that called Toño Muñoa. I write Toño and say, can I write you? Because I want to meet her and know more about the PIT Doppler. And Toño said to me, yeah, write to her. He's very available. Okay. I text Jill and I hope to get an answer. But the amazing thing that I have an answer in a very, very, very short time. And Jill text me and say, do you have a WhatsApp? Can we talk? And when we talk, say, do you have time on Sunday? Yes. Okay. See you at Zoom meeting on Sunday. And that Sunday, we have a 2 hours masterclass with PIT Doppler with Jill. And that's how we start our friendships. And that's how I start doing the PIT Doppler with my patient.
That's pretty remarkable. I mean, what's really, I think, so incredible is that here's a doctor. I think it's great for patients who are watching and listening to hear that this is a doctor that is continuing, not resting on his laurels and what he learned in medical school, but actually truly continuing to learn and grow and thinking about how can I do more for my patients? What were your struggles? What really kept you up at night that drove you to search for answers?
Here in El Salvador, 5 years ago, to evaluate our diabetic foot, we only perform the ABI, but right now all know that the ABI in diabetic foot is not the best thing that to perform, to know the vascular artery in the foot. So we changed and start doing the curve flow of the toes, and then we perform arterial plethysmography. But there are not so specific where is the trouble is. So that's why I start looking what to do more and best for my patient. That's why when I read and met Jill and see the pedal acceleration time, wow, it's amazing how the PIT Doppler can help to make a very good diagnostic on our diabetic foot and try to make a very good treatment to our patient, try to avoid a major amputation.
And just to recap with everyone, ankle brachial index is that test where we put blood pressure cuffs around the ankle and the arm, and we compare those blood pressure measurements. But they can be false or have a false reading in patients with diabetes or renal failure because those small little arteries are filled with calcium and the blood pressure cuff just can't get an accurate reading. And so I think this is where the PAT Doppler, which is ultrasound directly looking at those arteries in the foot, and we can measure the waveform and have an objective number that's not really, it's very reliable in the diabetic patient. And when we come back from break, I'm really interested to hear Dr. Aragon's application in his patient population, especially in patients with mixed venous disease.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just cut the thing off?
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for.
Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Dr. John Phillips' spectacular vascular moment of inspiration.
This is obligatory. We have to do this every show, even if Dr. Phillips is out saving the piggies. Jill Somerset, vascular technologist, or you know what? If we were in Europe, we'd be calling you a vascular scientist, right? So you're just amazing. Helping to change the world, create the change we all want to see in helping patients with peripheral artery disease, the poor circulation in the legs. But moment of inspiration, usually Dr. Phillips has a quote. And so I want to ask both of you, do you have a moment of inspiration that you can share with us in honor of Dr. John Phillips?
Dr. Fernando and I are WhatsApping all the time, and it's always amazing because he does amazing work in El Salvador. The limbs that he is saving is amazing. So that's my moment of inspiration. It's amazing work.
So the words of inspiration, amazing. So that's going to be our word of the day. It'll be amazing. Why is this word important to you, Dr. Fernando?
For me, as a general surgeon, we love to be in the OR, making a big surgery and try to save lives. We're supposed to think that we only save lives in the OR. But when we start treating diabetic foot, and see the afraid of the face of our patient coming without no walking, and then you saw the patient return to your clinic walking by their own with a big smile. That is the best thing I ever saw in my patient when we save the foot in a diabetic patient.
And that is amazing.
Amazing, yes.
So before you met Jill, I want to go back to what was not so amazing for you and sent you on this journey to find answers for diabetic foot. Talk about the struggles that you have. Explain diabetic foot, the different types, and what the biggest issue with diabetic foot is for surgeons like you.
Okay, we have a big trouble here in El Salvador because diabetic foot, we only offer a major amputation for most of our patients. So like 20 years ago, I start with this journey with the diabetic foot and try to save as much as we can. So that's why we've been looking for all the tools that we get to get better and better and try to avoid a major amputation. The way is like a general surgeon, then I start doing phlebology. And in phlebology, it's mandatory that you have to perform our venous Doppler by our own. That's why I learned to do in Doppler. So to include the PIT Doppler to my practice, it was not so easy, but helped me a lot to know about the venous Doppler. And you know that I learned most of the PIT Doppler by Zoom. We, with the patient, we put a Zoom meeting with Jill, and Jill via Zoom told me all the tricks to perform the PIT Doppler to my patient. So that I think that is the amazing story because during the pandemic, we cannot go out. We've been meeting by Zoom all the time. I asked the patient if they can allow me to be in a Zoom with Jill, explain what I'm going to do. And when I start seeing that we can measure a very tiny artery on the foot and we can see where comes the trouble and to program a very good angioplastic to perform a better surgery in this patient. That's why I say that PIT Doppler for me right now, I perform all my patients that come to my clinic and to our hospital, we perform a PIT Doppler to perform the artery evaluation.
And just to recap with everyone, when we talk about PAT, which is pedal acceleration time, this is again ultrasound of the small arteries in the foot. And there's established criteria around this technique. So Dr. Fernando and I know, based on the criteria, how we measure the blood flow has 4 classification numbers. So class 1 and class 2 have pretty decent flow to a diabetic foot ulcer. If the waveform is abnormal and now you have a different class of PAT, which is 3 or 4, we know that a wound is not going to heal and we need to do some work to open up those blood vessels. But I think this is where it was really important for Dr. Fernando is, you see these patients with diabetic foot ulcers. And that ABI blood pressure test in the past was false. And now he has a tool to ultrasound the blood flow or the arteries around the diabetic foot ulcer and say, the flow is good. Let's just optimize the patient on medication, wound healing, offloading, or maybe the blood flow is bad and now the patient needs to have surgery to open up more blood vessels.
And Dr. Fernando, there in El Salvador, are you able to open up with wires and balloons those small vessels in the foot that are locked up and going to the wound? Are you serious?
Yes, but only in the private practice, and it's too expensive. That was the project that we started 11 years ago with my colleague, Dr. Marco Fuentes, who is the one to perform the angioplastic. Try to get low cost as easy possible to our patient to perform the angioplastic and can open the little tiny. We have 0.3 millimeters catheters and balloons to do it, the angioplastic.
So Kim, his partner is an interventional radiologist, and Dr. Constantino and I went to El Salvador. I think that was 2023, right, Fernando?
Yeah, 2 years ago.
Yeah. So Dr. Constantino and I went down there, and we actually did a case all together. And Dr. Fernando and I were down at the foot, monitoring the PAT, and Dr. Fuentes and Dr. Constantino were doing the procedure. And all together, we did this really nice case, opening up the blocked artery, and we saw an improvement of PAT. And it was a really lovely experience, and I can't wait to go back.
No, and you know what is amazing? When we in the OR, the team working together, after they perform the angioplastic, you can measure with the PAT Doppler and see the difference after the angioplastic and before the angioplastic.
Bring me back to that moment, Dr. Fernando, where you actually, for the first time, were literally with the Doppler experiencing this real-time perfusion of the foot based on someone going in with wires and balloons performing angioplasty, where the balloon dilates. That's what angioplasty is, to push the plaque aside to clear up the blocked roadway and allow the traffic to flow through, the blood flow to get through. What was that like for you? Did everyone just erupt in cheers? Did you have tears? I know that rhymes.
No, it's kind of amazing because after that, perform the angioplastic, but you not be so sure that if you perform in the OR, it's okay to have the wound healing. So right now with the PAT Doppler, you are 100% sure that if you perform a very good angioplastic, the wound healing is going to be excellent in that patient. It's kind of amazing because you see all that foot that all the people only say, no, they're going to need a major amputation. But after a very good treatment of the wound healing after the angioplastic, you see in 3 months, 4 months at most, the wound healing completely closed.
And in the last quick 30 seconds here, I just want to explain to people, and maybe you could just do it. Why is blood flow so important for wound healing?
Without no blood flow, it's not going to heal the ulcer.
There's no oxygen, there are no nutrients getting to it. It's basically starving the tissue of any nutrition.
I always say my patient there is 2 ways that they are going to end in a major amputation, because we cannot control the infection or because we don't have enough blood flow in the foot.
And coming up right here on The Heart of Innovation, we're going to have more with Dr. Fernando and vascular technologist Jill Somerset, my guest co-host for the day. So stay with us. Don't go away. You're listening to KDOW in The Heart of Innovation.
Your type of condition is called critical limb ischemia. It's the most advanced form of PAD, or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to PAD and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with PAD.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane. The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options. We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back, everyone. Thanks again for tuning in. You know, I'm here with Dr. Fernando Irigoyen from El Salvador, and thank you, Kim, for the invitation for us to be here and share, you know, all of the great work that he's doing in El Salvador. But I really just want to highlight, you know, him and I go back and forth on WhatsApp, and we've known each other, for 6 years. And, you know, he shares these pictures of these patients that arrive in his clinic with significant wounds of these diabetic foot ulcers. And he's using this technique called pedal acceleration time, or ultrasound of the foot, to measure the blood flow. And, you know, in the past, Dr. Irigoyen, you would assess the diabetic foot ulcer, do an ABI, and that would be false. And you weren't sure if there was enough blood flow, and perhaps that patient went on to amputation. But you know, after we met in the pandemic and I trained you, now your algorithm of saving these diabetic feet is a bit different. Can you speak to, let's say a patient arrives into your clinic with a significant diabetic foot wound. Now, what is your plan?
First of all, I always say to all the colleagues that you have to sit with the patient and make to be the friend of the patient. All the diabetic patients that came to us are afraid because all the colleagues said that they need a major amputation. And when they hear a different evaluation, they hear there is something that you can do to avoid that, the face of our patient changed. And I try to explain them that we are going to perform the evaluation to know how is the infection and how is the flow of the foot. So I explained that we are going to try to measure a little tiny artery on the foot, and the plan of the pedal acceleration time is not to get a worse pedal acceleration time. I say that like a school, I need to pass the test, not to fail the test. So I take my time to perform the PIT Doppler. Yeah, at the beginning, take me 1 hour to perform. Right now, I perform in 15 minutes. So it's easy to do it when you got the skill to perform. So when I show the patient without no measure, and I say that, here is your trouble, we have to fix them with an angioplastic, and then we perform the angioplastic and perform again the PIT Doppler, and they listen the sound of the PIT Doppler. You don't imagine the face of the patient and the family when they say, so the foot is going to be safe. I hope so. Because
can you also speak to your medical optimization with these patients? What kind of medication do you put them on? What's their wound healing? What's your plan?
Yeah, and that's the point, that most of the diabetic foot only think that we're going to give them antibiotics to heal the wound. And it's not only that we are going to give them, we anticoagulate most of our patients, trying to explain them what is going to be happen if they don't take the pills or the anticoagulation in the proper way, because I know that they are afraid that make a bleed of the brain or make a bleed of the stomach, but I try to explain them that it's going to need that medication. And if they take in the proper way and how we indicated the treatment, there's going to be no anything wrong to take that. Maybe the worst patient that we have is the patient with a kidney failure. When they have the kidney, most of the patient and in a major amputation. Even we perform the best angioplasty, the best treatment as the worst patient that we have. That.
Yeah, the chronic kidney disease patients also, just like diabetics, get a lot of below the knee disease. But what is really tough about a chronic kidney disease patient is that they can't tolerate the contrast fluid that is required for these procedures for angioplasty to be able to open up the arteries. And I would imagine there in El Salvador, you don't have the alternative CO2 to use on them. But there are a lot of doctors out here that are also using external ultrasound to help them in these types of procedures. And you're nodding your head. You try to do those when you can as well.
Yeah, we cannot be able to use a lot of contrast to perform the angioplasty. We help with the ultrasound.
And just to go back, Dr. Fernando, so you put your patients on a anticoagulation. Do you also do a statin?
Yes, we put anticoagulation, antibiotic, an advanced wound healing. When we can't, we use anti-inflammatories, but only the kidneys is allowed us to use it. And sometimes we try to treat the venous problem too, because right now that's what I saw, that it's a mixed problem. Not only remember that the diabetic foot passed 3, 4, 5 months without no walking, so the venous problem, and sometimes we have a mixed problem in this patient. So it's very important to see if the ulcer is not only for diabetic, it is a venous problem too. So we have a different approach to this patient.
And before we go to break, I just want to ask about, do you offer them here? It's a big deal, Ozempic and Jardiance and Wegovy, all these diabetes drugs. Do you have any drugs there that lower the A1C?
No, it's not available here, but most of our patients be treated with oral treatment or insulin, but they have to inject every day. That's the problem, because there are a lot of medication that it'd be useful in this patient. We don't have it in El Salvador.
And coming up right here on the Heart of Innovation on KDOW, we'll have more with Dr. Fernando and Jill Somerset, our guest co-host of the day. So stay with us. Don't go away.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAT, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link for circulation and pain. Left untreated, your leg might end inflamed.
Welcome back to the show. Dr. Phillips has the day off, and vascular technologist, world-renowned vascular technologist Jill Somerset is here as my guest co-host. Very lucky to have her and her friend from El Salvador. He's a general surgeon. It's Dr. Fernando Irigoyen. I got it that time. I'm learning how to roll my R's a little bit better. My Spanish teacher would be so happy, Mr. Lozano. So happy to have you here. You're making such a difference in terms of the lives and limbs of patients over in El Salvador, in taking time to say, hey, you know what? I don't like the way things are done here. I don't like my limitations. I'm not going to argue for my limitations. Instead, I'm going to find a solution. I can't save all the limbs that I want to save of patients who have poor circulation in their feet and in their legs, whether it's arteries or venous, their veins. I got to do something about this. And you did. And you brought Jill and also her friend and her colleague, Mary Costantino, who's an interventional radiologist. You brought them over to El Salvador and they taught you some new tips and tricks in order to save limbs. And since implementing, especially the pedal acceleration time, where you could measure that perfusion clear into the smallest arteries in the toes in real time, what tangible impact has this had on reducing amputations in your area of El Salvador, or at the very least in your practice?
You know that 5 years ago, maybe we perform 2 major amputations a month, every month, a lot of amputation in my private practice, of Okay. But right now, doing a very good vascular evaluation in the patient, because we not only perform if we have a diabetic foot, we now start performing PIT Doppler in diabetic patient, because we have to prevent, and we can see if they have a mild ischemia, for example, a PIT Doppler 2, we start treat them before they get a diabetic foot. So right now, we only perform in this year one major amputation.
It's so far in 2025, only one.
Only one. And we have more patients than 5 years ago.
So what impact has this had on influencing other physicians and even hospital administrators and possibly the government and who runs the public hospitals to implement a technique like this and to go the extra mile for these patients to save their legs? Because an amputation is not only a cost of a limb on the patient, right? But it literally has a huge burden financially and socially on our entire society.
I think, first of all, is the ego.
Oh, no.
Our doctors, I think, when you say you have to perform an ultrasound, go to the radiology. I'm a surgeon. I only perform the surgery. They perform that. So I think it's the ego. That's why it's kind of difficult to implement in most of the country.
But couldn't radiology adopt this practice and pair up with these surgeons in order to improve the outcomes? I mean, that could be an answer, right?
Yeah. That's what we are working on that. And every time I be in the stage or in the podium, I try to explain all the colleagues what the PIT Doppler helped me a lot in these 5 years to improve my treatment in the diabetic patient.
So you actually speak across the globe. Where do you feel that you've had the greatest influence in speaking to doctors and getting them to adopt your way of thinking and your tools and your techniques that you have learned along this journey since meeting Jill and Mary Constantino?
Maybe in Italy, a lot of radiology come to me and say, can I have the name of the creator of the PIT Doppler? Because it's very interesting, the technique that you present right now. So I think when they saw the how the PIT Doppler can help us, and how you see because it's not only to make the first evaluation in our patient, it helps us in the OR after the angioplasty and help us after the angioplasty to make the control of our patient if they are still open at the artery. So in Italy, I think is the most very, very interesting in the technique.
Fantastic. Well, coming up right here on the Heart of Innovation, we'll have final thoughts from both Dr. Fernando Irigoyen and vascular technologist Jill Somerset, my guest co-host for the day. So don't go away.
You know, the collaterals are the other networks that form then when there's a blockage. And that was discovered probably 70, 80 years ago by, I think it was Dr. Hunter. He was doing some research on reindeers, and he went into the neck area and clipped off the vessel that was the main one to the antlers. And then he saw that they stopped growing and they got, they weren't going as much. Everything stopped. But then he waited like 6 months later and he saw them start growing again. So then he went back into the neck and to look to see what happened. And he saw these vessels going around the artery that he had clipped off. It just took a while for those collaterals to form. So that's what, can happen. If you have an artery that's blocked and you walk and exercise, your body's going to try to build those collaterals naturally, but then you're going to help build them even more by doing some walking, you're going to help accelerate that process and make those vessels even bigger so that you may not even need some type of intervention.
Hi, everyone. Welcome back to the show. We're rounding third, headed for home, as Dr. John Phillips would always say. Except he's off saving those piggies. He'll be back next week, but we're honored to have our guest co-host for the day, vascular technologist Jill Somerset, and her friend, Dr. Fernando Irigoyen. And we're talking about pedal acceleration time. It has been a game-changing technique for Dr. Fernando and his practice, reducing amputations from 2 a month, major amputations from 2 a month to literally only 1 in 2025. Absolutely amazing. And now he is traveling the world trying to spread the message on the impact of pedal acceleration time, or PAT, which was developed by Jill Somerset. And I'm curious, from your perspective, Fernando, if anyone is interested after listening to the show, like, what advice would you have on bringing this into your practice or their practice?
Like I said at the beginning, I start doing PIT Doppler via Zoom. And when the airport opened, the first flight I took was for Oregon to meet Jill in person and try to myself to improve the PIT Doppler technique. So right now, for example, we have our Congress, the Diabetic Congress, this year. We are going to perform a workshop that Jill is going to be here to teach all the people that want to know the technique. So I think to learn is very easy. You only have to have the how to say it in English,